Professor Chuckuka, ele tem uma longa história de desenvolvimento na laser terapia. Ele foi da Universidade de Kansas e por muito tempo ele foi o presidente da World Association for Laser Therapy, WALT. E ele foi um presidente muito ativo. Como vocês sabem, a laser terapia é uma modalidade terapêutica extremamente eficiente, mas ela tem que ser bem feita, né? Sem excessos de entusiasmo e sem viagens para o cosmo. E durante a presidência do professor Chuckuka na WALT, ele de fato fez questão em mostrar que esse era um campo científico mais do que uma curiosidade. Ele é hoje co-editor da revista Photomedicine and Laser Surgery. E, evidentemente, ele tem grandes colaborações em todo o mundo, inclusive no Brasil. So, for us, it's a pleasure to have Dr. Chuckuka here in São Carlos, and I hope this is a beginning of a long collaboration.
Thank you.
I already made an introduction in Portuguese,
Yes.
and I'm sure that you're going to give us some details that I wasn't able to present then about your career and your own person.
Thank you.
So, Professor Chuckuka,
Thank
please.
you very much. Good afternoon, everybody. Boa tarde a todos. I wish I can speak Portuguese, but I just know very little fala português pouquinho. So please forgive me if I speak, that my lecture is going to be in English. I'm really very delighted to be invited to your very beautiful institution and your esteemed Institute of Physics. When I was talking to Dr. Banyato about this, he thought maybe the best thing for me to do is to give a lecture that gives you an idea of all the research that I have done. But it's very difficult to do this in 2 hours because I have been doing research work in this field for more than 20 years. I started when I was a little baby, so if you think I'm old, I'm not old. I'm just, I was very young when I started doing this. I'm just joking. But I thought that maybe just to add to some of the things that he said to you, you need to know that I started off my academic life in Nigeria, where I went to school and received a degree in physical therapy, and then went to Southern California in Los Angeles and got a master's degree. And then I moved across the continent of the United States to New York and received a PhD in pathokinesiology from New York University. But I stayed at NYU, New York University, for some time for postdoctoral research work in cell biology. And then eventually became a fellow of the American College of Sports Medicine. And the lines in green show some of the places that I have received some greens. In the US, you say you received green, it means you were paid money. These are places I worked and I was paid. First as assistant professor of cell biology and physical therapy at the University of Texas Health Science Center at San Antonio. And then associate professor of orthopedics and rehabilitation at the University of Miami in Miami, Florida, and then went on to the University of Kansas Medical Center in Kansas City as professor and chairperson of physical therapy and rehabilitation sciences. It was from there, after 10 years, that I moved to the New York Institute of Technology as professor and dean of the School of Health Professions there. Over the years, I have been very fortunate to have held some positions of recognition. One of them being that I was one of the past presidents of the World Association for Laser Therapy, and also the founder of the North American Association for Laser Therapy. And I was past editor-in-chief of laser therapy, and this journal merged with the Journal of Clinical Laser Medicine and Surgery to create a new journal in 2004 called Photomedicine and Laser Surgery, of which I'm co-editor-in-chief of this journal. Before I continue with the lecture, I'd like to show appreciation of some of the people that collaborated with me, so many of them to list. Most of these people, the names in white, are research fellows and research assistants that worked with me. The names that are shown here in pink, I'm sorry, the names, yeah, these are research fellows and assistants that worked with me at the University of Texas Health Science Center, San Antonio, and the ones in pink here are the ones that worked with me at the University of Kansas Medical Center in Kansas City. The individuals here are faculty and colleagues that worked with me from different departments over the years. I don't have all the names, but that gives you a good idea. Before I moved to New York Institute of Technology, I used to run a very big laboratory setup, about 2,000 square feet of laboratory space. Also, I like to acknowledge the support of the National Institutes of Health. Most of the grants that I used to do the research was from the National Institutes of Health, and also from the VA, the Veterans Administration hospital system that also has national research awards and fellowships. And similarly from a number of foundations as well. I started off my research career basically at the University of Texas Health Science Center at San Antonio, and this slide shows the campus, and this shows the VA hospital in Miami, Florida. My laboratory was located in this hospital, somewhere on one of the floors of this building here. And of course, this is the beautiful campus of the University of Kansas. When I showed this slide for the first time in Brazil, everybody thought that maybe the trees were colored. No, these are the colors of these trees in the fall. In October, November, December, the leaves change from green to different colors. And the campus is usually very beautiful at that time of the year. But my laboratory was located in this building at the University of Kansas Medical Center in Kansas City. For this presentation, we will first of all start off with some of the early work we did looking at how connective tissue adapts to different conditions. And I'm going to use some examples of immobilizing connective tissue, an example of effect of physical factor and phototherapy to demonstrate for you that connective tissue adapts to different conditions. In fact, if you start dieting today, and I know that a number of people are involved in dieting and food restriction, when you do that, it doesn't normally occur to you that your tendons, your ligaments, your hair, and bone, all of them adapt to the food restriction. When you lose weight, you think you lost fat. But you have also lost some bone mass. You've also lost some tendons and some ligaments. We have papers from many years ago showing that this is the case. So I will refer to some of those. And then in the second part of this, I will bring you up to date on what we're doing today. We have done some experiments, laboratory research, looking at the effects of phototherapy on diabetic ulcer repair in laboratory animals, and then now in human cases of diabetic ulcer repair. As a matter of fact, the human studies that I'm going to refer to is currently underway, not very far from here, just 1 hour drive to Ribeirão Preto, where we have a group of people that are doing the work as I speak to you. And then I'll try to bring this to a close, hopefully within the 2 hours. Just to give you an orientation, connective tissues come in different forms. They are either loose or dense. For the purpose of this discussion, we're going to limit ourselves to dense connective tissue. Loose connective tissue such as blood, we're not going to talk about that. When you look at dense connective tissue, other than bone, if you look at tendons, ligaments, and skin, you find that these structures, these tissues, have very few cells in them. They are made up of masses of collagen. the collagen in these tissues are arranged in some format. For example, in skin, the collagen fibers in skin run in all directions. This should not be surprising to anybody because skin takes forces from different directions. So the collagen, in order to withstand the forces that the skin is made to bear, is arranged and organized in different directions. They run in different directions. So basically, collagen arrangement in skin, ligaments, tendons, and most structures, even in cartilage, is based on the direction of force or the direction of force that is applied to that tissue. So if you move from skin to ligament, you find that the collagen fibers run mostly in one direction. However, there are collagen fibers that run across obliquely to the long axis of the ligament. And from time to time, you find some elastic fibers, which I try to show in this wavy structure here, within the tissue. So basically, this is the arrangement in ligament because ligaments bear force mostly from one direction. Ligaments function as braces for joints. They support the joints. So when you move, the joint moves just usually in one axis. If it is in so many axes, there's a ligament for one axis, another ligament for a different axis, and so on and so forth. Most of the forces applied to the ligament come from one direction. When you move from skin through ligament to tendon, now you're dealing with a structure that receives force only in one direction because the tendon attaches to muscle at one end and then to bone at the other end. So when the muscle contracts, it pulls the tendon. And it pulls that tendon usually in one direction and only one direction. Because of this, the collagen structure of tendon is mostly parallel to the axis of the force applied to the tendon. And a few times you find a few elastic fibers in the tendon. Now, if you, because of this, several years ago, a gentleman whose name is Kastelik at Case Western Reserve University and his colleagues decided to show the structure, to study the structure of tendons. And what they found was this, that within each tendon, we have bundles of collagen. And those bundles of collagen he referred to as fascicles. Within each fascicle of collagen, we have individual collagen fibrils. Most people refer to this as collagen fiber, but technically that's not correct. The correct term for it is fibril. So within this bundle, you have individual fibrils, and you can visualize this fibril under the electron microscope or scanning electron microscope or the X-ray microscope. Below the level of the fibril, you can actually see fascicles with light microscopy. And of course, you can see the whole tendon with your eyes or with a light microscope. If you go below the level of the fibril, what you have are structures that are usually not found outside the cell. And of course, the cell that produces this collagen are known as the fibroblasts. Outside the fibroblasts, you wouldn't find these fibers. If you find, you wouldn't find subfibrils and microfibrils and the collagen molecule. These are usually found inside the fibroblast, and the fibroblast then assembles them. They polymerize once they are outside the cell, and they form the fibril. What this means is that the functional unit of collagen is the fibril. That's what you find outside the cell. That's what withstands all the forces. That is what is going to adapt to any change or anything that you do to the tendon or to the skin or to the ligament. These structures will adapt to that force and to that intervention. However, you have to look within the cell to see how this is changed within the structure. So we find that this tendon structure is very, very good because it is very orderly, the arrangement is very nice, and it becomes a very useful tool for studying the effects of different factors on collagen. So over the years, when we first started our line of research, we did a lot of work with tendons. We studied in particular changes at this level of the fibril. How does the fibril change? For example, if you were to have a patient in the clinic and the patient has a cast put on, what happens to the tendon? Does the fibril remain the same? In the previous slide, I showed you how orderly they are. What happens to this orderly arrangement of the fibril? Does it change? Does the fibril get smaller or bigger? Some of these things we were very much interested in. And so we used electron microscopy to study these changes over time. And then in the course of doing electron microscopy, we also did morphometric measurements using the computer. If you do electron microscopy of a tendon, this is what you're likely going to see. You will see what look like circles. Each of these circles is nothing but collagen fibril. In this case, the fibril, the tendon has been cut in this direction, and the fibrils are running in this direction, sticking in this direction. If you look longitudinally, you will see what looks like that. You see the fibrils are parallel to themselves, and they have striations on them. This is orderly. This is very nice. When there is intervention, this is going to change. So this is the reason we use this model. From time to time, you will find that within these bundles of collagen fibrils, you find a cell, the fibroblast, sitting in the structure. This fibroblast is usually not active under normal circumstances. In fact, those of us who do cell biology know very well that this is not an active cell. I know this because if you look at the nucleus, it is very dark, and you have clumps of chromatin. They are not evenly dispersed. In fact, I will show you very soon an active fibroblast, and you can see the difference between them. Moreover, the cytoplasm is very thin. The nucleus is very big and prominent, as you can see there. And the cytoplasm is just very, very thin and dark all around the nucleus. We studied the effect of immobilizing this tendon in order that we can understand the model that we use to study the effect of light, the effect of ultrasound, the effect of electrical stimulation of the tissue. One of our earliest studies, in 2 hours, by the way, it isn't possible to show you everything, so I'm just going to give you some ideas. I will pick from here and there and there, and then hopefully at the end you get a complete picture. In one of our earliest studies, we had 5 groups of animals that all we did was just to put a cast to immobilize the limb of the animal in plaster. No surgery in any of them. Normal tendon, no surgery, nothing whatsoever, just put a plaster on the animal and just to see what happens to this tendon structure. And so we'll have group 1, which had no cast, so this is our control group. And group 2, we immobilized for 3 weeks. And group 3 was for 4 weeks, group 4 for 6 weeks, and group 5 for 8 weeks. Okay? When you do this, the animal looks like this. This is what the cast looks like. And the animal moves around and eats and does everything. It looks normal, like you don't see any change. When you take the tendon from normal tendon, no cast whatsoever, again, you see the same structure as I showed you before. The structure is very orderly. You have different sizes of collagen fibrils, quite some big sizes. This bar, by the way, shows the magnification factor, okay? And that also shows the magnification factor. But after 3 weeks of putting the cast on the animal, you find that the collagen fibers, they look smaller. Curiously enough, they look smaller in size. And then you find that the fibroblasts are just sitting there, almost like you have in a normal tendon. They're not busy. They don't seem to be doing very much. But then you find that the membrane, these are 2 bundles. This is one bundle of collagen here. This is another bundle of collagen here. This is the endotenon, the membrane that is supposed to surround this bundle of collagen. And this is the membrane that surrounds this bundle of collagen. Under normal condition, you don't see this at this level of magnification. At this level of magnification, because we're able to see the membrane, we realize that the membrane has become thickened. And it has become thickened, but then it also has some deposits of materials along it, which we couldn't recognize here. However, by the time you get to 4 weeks of immobilizing the tendon, you find now that the thickening is even worse. These are two adjacent bundles. These are supposed to be longitudinal. We realize that this thickening is due to deposition of lipids and fat on the membrane. And you see from the structure of the collagen that the collagen structure has become disorganized, completely disorganized. In clinical practice, a lot of people refer to this as fibrosis of the collagen, okay? But it is so disorganized that you cannot tell whether these structures are running parallel or longitudinal or one way or the other. By 8 weeks, the disorganization is so severe that some fibers are actually running are in cross-section, some are longitudinal, some are oblique, and in fact, you have a whole area of the structure that is devoid of collagen. And it seems filled with some deposited material that we don't know what it is. So we realized from this study that putting a cast on an animal is not a good thing to do, or even on human beings for that matter. Can you imagine, this is normal tendon. If this was if this was a patient that has injury to the tendon, and now you put a cast on top of that, the cast is going to do this type of damage to the tendon. And the tendon is already damaged to begin with. So the patient is going to get worse than the patient was before. So once we published this study way in the 90s, early 90s, we became actively involved in finding a way to reduce this type of effect. And one of the things we found that was valuable in reducing this type of effect was physical activities, ultrasound stimulation of the tendon, and phototherapy. But look at what happens to the size of the collagen, by the way, because we measure the sizes of this collagen. You find that in control collagen, we have about 23,000 square nanometers cross-section. And as time progresses with immobilizing the tendon, the size diminishes. In fact, by 8 weeks, it is about half the original size. So not only is the structure disorganized, there is also atrophy. Just like you have muscle atrophy, you have atrophy of the collagen. It turns out that this finding is very similar to what was reported by Frank Noyes from Cincinnati Sports Medicine Center many years ago when he studied the anterior cruciate ligament of primates. And he found that if you immobilize that anterior cruciate ligament for 8 weeks, the amount of load that ligament can bear is reduced to 61% of control normal ligament. And then the energy absorption capacity is reduced to 68%. Also, after 8 weeks. When Frank Noyes published this study, nobody could explain why this would happen. But you can see from our result that this is easy to understand because the collagen has been atrophied to about 50% of the normal size after 8 weeks. And the structure has been disorganized as well. So this is very interesting that in tendons, we got about 50% reduction in the size, disorganization of the fibers, and also in ligaments, they found something very similar in terms of the biomechanical load or capacity of the ligament. Now you find that after 8 weeks, if you put those animals, the primates, on exercise program, and they start running on treadmill, and you start doing some type of rehabilitation, after 5 months, you only regain 79% of the normal strength and 78% of the energy absorption capacity. In fact, after 1 year of rehabilitation of these ligaments, you still don't have normal strength or normal energy absorption capacity. You have 91% and 92% respectively of the strength of the tendon, the ligament, or the energy absorption capacity of the ligament. So this is a very bad thing to do to use in clinical practice. But in clinical practice, it isn't possible to just repair a tendon and not immobilize. You have to immobilize the tendon. If you do not immobilize the tendon, the patient can re-rupture that tendon again. And then you have more problems. So the question is, how much is good? And how little is enough or not enough? We spent most of our early studies doing this, looking at different periods of immobilizing the tendon in laboratory animals. In fact, what we came up with was that 5 days was enough in the rabbit model. And after 5 days, you can remove the cast and then allow the animals to move around. All of those were based on electron microscopic studies of the structure of the collagen as it matures, as it heals from day 0 to day 5 to day 7 to 12 days, 14 days, 21 days, and so on and so forth. I won't share that data with you, but once we did that, we were able to convince that that was the case. We also, as part of our initial studies, looked at how different regions of the tendon respond. If you cut a tendon and you suture the tendon, is the healing process limited to the site of the surgery? The reason we asked this question was very simple. In all the animals we studied, we found that when we cut the tendon and suture the tendon, you come back and you try to examine the tendon, remove the tendon, and process for electron microscopy, the entire length of the tendon is swollen, not just the site of repair. So if the healing process was limited to the site of repair, then the whole length of the tendon should not be swollen. Only the site of repair will be swollen. So if there's swelling all along the length of the tendon, it means something is going on all along the length of the tendon. So we took some animals that you saw the structure, again, the same rabbit model. And what we did was very simple. After the surgery, and this type of surgery is called tenotomy, it simply means cutting the tendon across. And then you suture this end. And after a period of time, 2 weeks, 3 weeks, in this case it was 2 weeks, we took out the newly formed tendon at the site of the surgery. We call that new tendon. We went proximal to that site of surgery. We took a piece of tissue in this area and we discarded it, threw it away because we suspected that this will have a mixture of new tissue and old tissue. So it cannot tell us what happened to the old tissue. To get an idea of what happened to the old tissue in the proximal region of this structure, we took a sample from here and processed for electron microscopy. We did something similar below. We discarded tissue from here and took our specimen from here. And we did electron microscopy of them. This is what you find. You find that in the proximal region of this structure, you find cells that are very active. I mean, remember I showed you a fibroblast that is not active. The nucleus was very dark. There were clumps of chromatin. The cytoplasm was very thin and small. But look at this nucleus here. Look at that. In fact, this cell is so active, if you can tell because you can even see the nuclear pores that are open, allowing communication between the nucleus and the cytoplasm to occur more readily. And the cytoplasm, of course, is very huge, that the slide cannot even contain it. So we find that the cells are very active in the region that is proximal to the site of the surgery, meaning that that region is also undergoing some type of process, repair process. And you find this type of structure also. Here's a fibroblast. What we found was, in this case, we see this large vacuole, and it has what looks like collagen. In fact, it is collagen because you can see the striations of the collagen. Not only that, the fibers are running parallel to the same fibers that are outside the cell. And you find a very long strand here of collagen. This is not normal. You don't find this normally if this cell was producing collagen, you will not see the collagen fibers inside the cell. You will not. You will only see the molecules are formed and then they are extruded and polymerized outside the cell. So this indicates to us that this cell was busy trying to resorb existing collagen, to engulf existing collagen and reprocess as a part of the repair process of the tissue. Again, proximal region. You can even see here we find a macrophage cell that is loaded with collagen fibers. Here, collagen fibers, all enclosed in vacuoles, all of them. There's no freestanding one. They're all inside vacuoles. And you see this strand here. Look at the intersection between this strand of collagen and the membrane. See that? It indicates to us that the cell is resorbing the collagen, the existing collagen, so that it can be reprocessed as part of the repair that is taking place further down in the tendon. Not at this side, but further down in the tendon. The same thing you see here too. And this is at the site of repair. At the site of repair, you find highly metabolic and active cells. And you can tell again from the structures that you see very patent open pathway between the nucleus and the cytoplasm. There, over there, and somewhere there too, over there. And then you find the collagen on the outside. See how small they are? You can barely see them. These are newly formed collagen. They're very small in size. They will eventually polymerize and get bigger. The same thing you find in this structure here too, at the site of repair. Also at the site of repair. And then you even find now, again, the same macrophages are busy trying to organize and trying to reprocess and helping the fibroblasts to process this. At the distal end of the tissue, you find, again, now here we have a myofibroblast, also busy resorbing existing collagen and trying to get it in and reprocess for repair. Same thing here. So obviously, the healing process of any tissue is not limited to the site of injury. It occurs throughout the length. In fact, we should have even known this from common sense. And I will ask you the simple question. When you have a cut or an injury to any part of your body, do you not feel pain all along, assuming it is in your hand? You are going to feel pain not just at the site, but all around that site of damage. So it makes a lot of sense to understand that this is what goes on. In some other studies, when we were about to change our line of research, and I know that most of you are interested in phototherapy. I will get to phototherapy in a few minutes, but I'm just going to lay the groundwork for this. But when we were about to change our protocol, we started off in the days when plaster of Paris was used to immobilize the animals. And at some point, we wanted to change to fiber, to synthetic fiber, very polypropylene synthetic fiber, very light but strong and capable of doing the same job. I told my research assistants and fellows that this is going to cause a problem with our data, because we had so many years of data with plaster of Paris used in all the studies, and that if we change this plaster to polypropylene fiber, that the data is going to be different. In order to resolve this argument, we decided to do an experiment to compare what happens when you use plaster, which is heavier, and the animals cannot be as functional when you mobilize them with that, versus when they are immobilized with synthetic fiber, which is very light and very functional, and the animals can move around and function very well. Okay? We did this experiment. So here is our cartoon of plaster formed around the animal's limb, and here's our cartoon of polyurethane foam. We use Velcro instead of plaster. This is very light. In fact, this weighs about 6 times as much as this. And you put them on the animals, you don't realize this, something as small as this affects the tendon. Look at, we did biomechanical test. We took the tendons out after 2 weeks of being in this type of cast. We put the tendon between these two clamps. This is a materials testing system. Some of you are engineers, so you're familiar with this. This is used by engineers to test materials. So put the tendon here, and of course you push the red button over here, and the tendon is yanked apart, and you get some of this data. And you look at the tensile strength. With the functional cast, the strength of the tendon is 70% more than with the plaster. This actually demonstrates not just that the functional cast is better, but it also shows that these tissues respond to anything, every little thing, they respond to it. Something as simple as just changing the size and the weight of the cast affects the outcome of the experiment. So basically, all I have tried to show you so far is that connective tissue matrix is highly plastic. Plastic in the sense that it changes very easily, depending on the forces that are acting on it. It adapts readily to physical factors and other types of interventions. And most of this we have published in a number of papers from the past. And we have actually looked at the effect of functional activities on normal and repaired tendon and found that with function, if you immobilize, like I said earlier on, we determined that 5 days was enough in this model. If you immobilize the animal for 5 days, you remove the cast completely, the plaster, remove it completely, and allow the animals to move around. The tendon gets stronger, there is no re-rupture of the tendon, and the animals begin to walk normally after a short while. That line of research became so popular in the late 80s into the early 90s that it now is part of orthopedics practice. Today, orthopedic surgeons do not immobilize any human being, at least in the United States. They do not put a cast. After Achilles tendon rupture, they do not put a cast for weeks. The most they will do it is 2 weeks, usually 10 days. And that cast is removed, taken away, and the patient is put in a boot, a cowboy boot. And that's enough to hold the tendon in place so long as that patient doesn't leave the hospital and go and jump to play basketball, patient will be fine. If the patient goes to play basketball with this, they're going to re-rupture that tendon. So the patient is cautioned not to engage in too much activities for the next 2 to 3 weeks. So this has become standard practice. When it became standard practice in the United States, it became very difficult for me to get grants to continue with that line of research. Because everybody, the grant reviewers would write back and say, well, we're already using this in the hospital. There is no more need to understand the mechanism. We don't need to understand the mechanism. It works for the patients. We get good results with it. There is no need to continue that line of research. So we then changed our line of research and changed to diabetic ulcer studies. As you find out very soon, diabetic ulcers can be serious problems. But basically, we also did look at the effect of food restriction on normal tendons as well, and we published quite a few papers in that area also in the past. And we looked at the effect of, before we started the diabetic ulcer studies, we did some tissue culture studies, wherein we would take a tendon, for example, and soak it in glucose for weeks. Put it in glucose and see what happens to the structure, and then eventually you do some biochemistry. And we found that following glycation, there was complete alteration of the structure of the tissue, indicating to us that that's how diabetes actually destroys the skin and destroys muscle and tendons and ligaments and so on and so forth. So now back to photoengineering of tissue repair. And as I said, we did quite a number of studies looking at tendon repair, looking at diabetic ulcer repair. When we got into this area, it was very exciting. I spent a lot of years doing this. First, we looked at the literature, and we found that as far as the literature is concerned, it turns out that light within the range, if you look at the spectrum, by the way, of electromagnetic spectrum, starting with ionizing radiation, cosmic rays, gamma rays, X-rays, going to the longer wavelengths of light through the visible range to infrared, microwave, radio waves, and so on and so forth. It turns out that if you look at the literature of what has been published, you could actually stimulate tissue repair. Stimulate tissue repair, as I have indicated here, by using light between 600 nanometers wavelength and about 1,000 nanometers wavelength. So somewhere in this zone is you can get stimulation for tissue repair and pain control. So based on the literature, we decided to use light in that range for most of our studies. The same rabbit tendon model was what we used to do our tendon studies. Basically, you cut the tendon, repair it, and after the animal has recovered, we treat the animals for about 2 to 3 weeks. In early experiments, we ran experiments for up to 3 weeks. In some of the latter experiments, we ran the study for only 2 weeks. And then we evaluated the treatment after that 2-week period of time. Tendons are problems. I mean, I think we've already talked about this. If you have a tendon injury, it's a very serious problem because tendons don't heal very fast. But as I said, the study has resulted in a new way of practice now that all of these complications of tendon repair have now been overcome with a shorter period of immobilization. The second experimental model has to do with diabetic ulcer study, in which we induce diabetes in animals using streptozotocin. This injection of streptozotocin destroys the B cells in the pancreas of the animals. When the B cells in the pancreas of the animals are destroyed, they don't produce enough insulin. When they don't produce enough insulin, the animals develop diabetes. When the animals develop diabetes, you can monitor the diabetes from the blood sugar. You measure the blood sugar, you find that the blood sugar is very high, out of the normal range. And so then you know they have diabetes, and then we can then begin to study what happens to ulcers that we induce in them. Okay. And then we evaluate the treatment after 3 weeks. Diabetes is a very serious problem, particularly in the United States where there's a lot of obesity in the US. About $1 billion is what we spend to deal with ulcers coming out of cases of diabetes. And 27% of those patients, they have chronic ulcers that require treatment for a very long period of time. Sometimes each year, a patient will spend about $40,000. The insurance companies pay most of that money, but that's a lot of money being paid for something that we might be able to prevent. So it is a very serious problem in the US. So our studies, we do biochemistry and do electron microscopy and biomechanical tests to evaluate the outcome of the research. I'm going to show you an example of one of the results we got with tendons, and then I'll move on to diabetic ulcer repair. In this study, for example, we did so many experiments trying to find the dose range that would be effective for tendon repair, to enhance tendon repair. We found that 1 to 4 joules per square centimeter of phototherapy is usually effective. And it doesn't really matter what the wavelength is. In fact, with 632.8 nanometers red light, 904 nanometers red light, infrared light, 830 nanometer infrared light, we got similar results. And then we applied the treatment daily, continuously for 14 days after the surgery. And then, of course, we did the evaluation of the animals. And then, we found in several of our studies that not all doses of light, of laser therapy, promote tendon healing. Again, this dose range was what gave us positive results, 1 to 4 joules per square centimeter. Not only did it promote healing of the tissue, it also accelerated the maturation of the collagen. And I will show you an example of with this study here. Here, for example, is a study in which we use red light, 632.8 nanometer wavelength, and we have a control group of 12 animals, and then we have an experimental group of 12. And remember I told you we had already determined in earlier studies that 5 days of immobilization was all that we needed. So both groups were immobilized, their limbs immobilized for 5 days. But during that 5-day period of time, there was a window we created through which we treated the animals with light, beginning from day 1 to day 14. And then we did the evaluation on day 14. I just shared with you the biochemical data. When we did collagen analysis, total collagen was increased with light therapy or laser therapy. But the cross-section, the cross-linking of the collagen did not differ. In fact, it was less with the laser therapy treatment. We became curious to find out how there could be so much collagen, but yet the cross-link was less. And what we did was what is known as sequential extraction of the collagen. And this is a very simple technique whereby you take the collagen tissue, you put it in neutral salt solution. A salt solution will dissolve very weakly linked collagen fibers. Okay? In other words, newly formed collagen will be dissolved, solubilized from the tissue. And then whatever is left, you put in acid solution, usually 6 normal hydrochloric acid, and you boil for hours. And then that is going to remove some collagen that is stronger than the newly formed collagen, but not insoluble collagen. So the acid will solubilize some collagen, and we call this acid-soluble collagen. And then you take whatever is left and put in enzyme known as pepsin, and this enzyme is going to digest this remnant of the collagen tissue, and then you get pepsin-soluble collagen. Again, now this is much stronger than that, and this is stronger than that. And whatever is left is your insoluble collagen, which is the strongest linked collagen fibers. So then you really want a large amount of this. You really don't want too much of this. You want this to be there in large quantity. Okay, so we did this, and what we found was that with treatment, the newly formed collagen is obviously higher than it is in the controls. The acid-soluble collagen is the same in both structures. The pepsin-soluble collagen is a little less with light therapy treatment. But the insoluble collagen is much higher with treatment. What this indicates to us, basically, is that the treatment with light is causing synthesis of very large amounts of collagen. And not only that, it is also causing the transformation of the newly formed collagen rapidly into the insoluble form of collagen, with these intermediate steps in between, but rapidly to this level. If we go back, you see the high quantity of collagen newly formed, no difference in this intermediately bonded collagen, not much of a difference here, and a huge difference in the level of insoluble collagen, indicating to us that this form of therapy is having an effect, which is the reason the previous biochemical results showed large quantities of newly formed collagen, of total collagen. But the cross-linking was not different. The cross-linking was not different because we were looking at a mixture of cross-links, a mixture of the newly formed, the insoluble collagen, the pepsin-soluble, and then the acid-soluble collagen. But this gave us more detail. What we learned from this experiment, and I think I should wait a little bit to say this because we didn't learn this until we started studying diabetic ulcers. Okay? But basically, this is our conclusion that this form of treatment, even with 1 joule per square centimeter of energy density, promotes collagen synthesis in regenerating tendons. And not only that, it also promotes the remodeling process whereby the newly formed collagen remodels very rapidly into insoluble collagen. We published quite a number of papers in this area looking at different wavelengths of light, and we also did some work earlier on looking at the effects of ultrasound, the effects of electrical stimulation. Then at one point, we decided maybe we should combine laser therapy with ultrasound, with electrical stimulation, because all 3 of them have positive effects on the strength of the tendon. What would happen if we combine the 3 of them? Maybe we'll get something even more, much stronger healing of the tissue than with each individual modality. We did this experiment, and I can tell you now that it didn't give us better result. The result was about the same. Statistically, there was no difference between using just laser therapy versus combining it with ultrasound and electrical stimulation and physical activities. We got about the same result. There was a slight improvement, by the way, with the multiple modality. But that improvement was not significant enough for us to recommend it. So this came up in a number of papers. We will now change our direction to the diabetic ulcer model, which I already described for you. And we induce diabetes in animals. Once they have developed diabetes, after about 2 weeks or 3 weeks, we create a wound on the back of these animals, and then we treat with light. We did this experiment with, again, using biochemistry, electron microscopy, and biomechanical analysis of the tissue. And basically, again, you create a wound on the back of the animals after you have induced diabetes and treat with light. In this data I'm going to share with you, again, is with visible 632.8 nanometer light, and then we did analysis. Again, you look at the collagen, total collagen, there's a slight increase. The blue bar is the laser-treated group. The red bar is the control. There is a slight increase in total collagen. And again, as in the previous experiment with tendons, there was no difference in terms of cross-linking of the collagen. And so we then did sequential extraction. And when you do sequential extraction, you get similar results as we got with tendons. You find that there's a huge increase in newly formed collagen, no difference in acid-soluble collagen, a slight decrease in pepsin-soluble collagen, and a big increase in the amount of insoluble collagen in this structure. Very similar to the same results with the tendon. This told us that something was going on with the tissues. What we learned after so many experiments with tendons and skin from diabetic rats was that it isn't good to treat these animals every day. It is not good to treat them every day. And what seems to be going on here, if you permit me to go back for a minute, is that we were treating the animals every day. So if the laser therapy is supposed to stimulate collagen synthesis, then it means we're causing synthesis of collagen every day. So we should not be surprised to find a large amount of newly formed collagen because we're stimulating this to happen every day. However, the collagen that was formed 2 days before has now matured into insoluble collagen with treatment. So you get a huge amount of this collagen. And then you get variable results in between. So we then realized that this was not good, that the best way to treat these animals, and of course we looked at the literature and found people were doing the same thing too, was to treat these animals only 2 times a week. 3 times a week or 2 times a week, but we resorted to twice a week treatment. And that's what we resorted to. So that in the human studies that I'm going to share with you, I'm going to review with you, you will find that we did treatment only 2 times a week, not 3 times, not every day. And the results are quite good. But to continue with this, we did biomechanical testing of the skin that we took from these diabetic animals, and we saw that there was some positive effect on the biomechanics of the skin. They had more energy absorption capacity. They were also tougher than the control. The green bar here shows normal skin, no surgery, no repair, nothing whatsoever. So this is the normal. The reason we put this here is so that you can compare after 2 weeks the strength, the energy absorption capacity we have for this with the treatment compared to what the normal should be. Okay, so this is just 2 weeks. This is normal, no surgery, nothing. But this, you should only compare these two, control versus experimental, and you see there's a very big difference. Okay? But then we didn't see a difference in the amount of load or strength of the tendon, of the ligaments, of the skin, I should say. neither was there a difference in the maximum stress absorbed by the skin. We transferred this result to human cases of diabetic ulcer because remember I told you diabetes is a very serious problem, not just in the United States, but all over the world. It is among the top 5 diseases that bring about terminate life in people. And even before then, people they get progressively worse than they were before, even with insulin treatment. And in fact, many times the patient progresses. If they have a wound, the wound gets worse, gets bad, and if it is in the lower limbs, the wound eventually results in amputation. The limb is going to be cut, and that's not very good. So we decided to see if this light treatment would help patients with diabetic ulcer to heal better. And we started this study many years ago at the University of Kansas Medical Center. And at that time, in the United States, the use of phototherapy was not approved by the FDA. The FDA did not approve it, and people couldn't use it for clinical practice. But we were allowed to do experiments with it. However, because it wasn't approved for clinical practice, the physicians there wouldn't refer patients to us. So it was very difficult to get patients. But we started the study there. It was designed as a completely randomized, double-blind clinical trial with crossover over a period of 10 weeks. With 5 weeks, during the first 5 weeks, the patient was treated with the equipment switched to position A and another 5 weeks of position B. In fact, you either start with A or start with B. It doesn't matter. You could treat with the equipment set to position B or position A, or start with A and switch to B. Either way is fine. But one of these two positions, A or B, is the real treatment, and the other position is fake, placebo treatment. So the patient will come in for physical examination, and then, of course, you measure the ulcer from the beginning. And then we do a treatment with 830 nanometer light. This is infrared light, 150 milliwatts for 20 seconds. And if you multiply that out, it gives us energy density of 3 joules per square centimeter. And the treatment was done 2 times a week. At this time of evolution of the technology, we had a device that created a spot size about this size, not bigger than this, 1 square centimeter. And because it was 1 square centimeter and the ulcers were quite big, we had to treat just at the margins of the ulcer, all around the margins of the ulcer. So 20 seconds in one spot, 20 seconds in another spot, 20 seconds the next spot, and so on and so forth, until we cover the margin of the ulcer. We thought this was a way to standardize it, because the ulcers came in different sizes. Big ulcers, small ulcers. A small ulcer will receive very few spots of treatment because it's small. A large ulcer will get so many more spots of treatment around it. Our first patient, we did about 7 cases before we moved the study to Heber and Preto, but because we couldn't get patients. We did about 7 of them. So this first patient, this shows the characteristics of the patient. But more importantly, the patient had seen our orthopedic surgeon for about 5 months, no improvement, no healing. And the patient then came into the study after we had done all the preliminary work, physical exam, blood tests, and all that. And here is the ulcer for this patient. And you find that this ulcer looks very small. I'm sorry. The initial size of the ulcer is very small, but this is a very bad ulcer. Those of you who practice in the hospital know that this is a dangerous ulcer because of the location. That's where the patient steps on every time the patient takes a step. And so this ulcer is going to get bigger and bigger and bigger, and eventually this toe has to be amputated. It will be cut off because the ulcer will not heal. So after 2 treatments, the first week of treatment, we saw signs that the ulcer was responding to light treatment. In fact, after 10 treatments, remember 2 treatments per week, so 5 weeks, this ulcer healed completely. And we were very excited with this result. Our very first patient healed completely, and the machine was switched to position A. If you remember, the study was supposed to be completely randomized, double-blind crossover. This patient never crossed over to treatment B, only received treatment A and healed fully. So we became suspicious that treatment A might be the real treatment, because the next patient, as you will see, also has a very bad ulcer. This ulcer is bad because if you look at the size, it looks fairly small. But look at all the tissues around the ulcer. They're in poor health. They're not very healthy tissue. So again, this ulcer is going to get worse, worse, bigger and bigger. And if you don't do anything to help this patient's limb will be amputated also over time. This patient did not respond to treatment with position B, but then when we switched to position A, the patient healed completely again. So we then became very excited because, and in fact, it became clear to us that position A looks like the real treatment, position B was not the real treatment. You have to understand that the machine we were using was made in Denmark and shipped to us from Denmark. And the machine was preset in Denmark, and so neither the therapists nor the evaluators nor anybody knew which treatment was real because we were using infrared light. And I have an infrared detector, but I wasn't going to allow the therapists and the clinicians to know which position produced the infrared. So they didn't know. I have to go back to this slide because I have to point out to you that we learned something from this patient. You have to take the measurement either before debriding the ulcer or after debriding the ulcer. You cannot take the measurement one time before debriding the ulcer or another time after you have debrided the ulcer. When you do that, you get this type of little problem here. But basically, the patient didn't respond to treatment B, but responded to treatment A. This patient, I showed the slide only to highlight the problem of diabetes. This patient's limb was amputated. The patient really didn't qualify to be in our study because the patient had gangrene. And with gangrene, we don't admit patients into the study. It was one of the factors that you don't use to admit this. If the patient has gangrene, you don't admit the patient into the study. But the vascular surgeon that was in charge of this patient insisted that we should try it, given the first 2 results. Thought maybe we could help the patient. But the patient had diabetes that was not controlled. And this patient's limb was amputated. In fact, after 3 treatments, they came back the next day, we were told that the patient's limb was amputated. But I use it to highlight how diabetes can be a big problem. Our case number 4 did not respond to treatment A or treatment B. No response whatsoever. So we became a bit disappointed because we thought we had got very good results all along. And we had many more patients, by the way. Patient number 5 and 6 did not respond. They were just similar to this. And our last patient also healed fully with treatment A, a total of 10 treatments, but did not cross over to treatment B at all. So in this preliminary study, we found that about 57% of the patients, 4 out of 7, responded positively to this treatment. And we found that not all the patients respond. And as I said, because the technology was new in the United States, this was in the late 90s, 1998, 1999, 2000. At about 2001, I began to apply. I contacted colleagues here in Brazil, and we began to apply for grant monies from the government here to support this type of study. And beginning from 2003, we got some money to do the research here. And now the work is being done at Ribeirão Preto, and we have my colleagues here. Actually, Deborah is sitting here. I just saw her in the back. She's right there in the back and sitting there. She's actually doing now this study as part of her PhD work. And Marco Andre Frage is a dermatologist at University of Sao Paulo in Ribeirão Preto Medical School. And Suzele Franca is chairperson of Biotechnology Department at UNIEP. And Jill Almeida was at UNIEP when we started the study, but it's now moved to Sao Paulo, and of course myself. The data I will share with you is about 1 year old. But on this visit, just yesterday I got updated. We have now seen 23 patients altogether. We have data here about on 8 patients or so. But we have now seen about 23. We have 1 more patient to go to complete the study. But I'm very happy to report to you that the study has been very good and very positive. All the patients seem to have responded very well. Here we have our first 8 patients. All have type 2 diabetes, and they age from 79 to about 47 years. And a lot of complications with each of them. Mostly high blood pressure was the complication. You can see that some of the slides are still in Portuguese. These are Deborah's slides. Okay. Basically, for them to participate in this study, they have to meet the inclusion criteria. They have to have type 2 diabetes. They have to be diagnosed with ulcer, with or without neuropathy. And it has to be at least 4 months duration. You can see I understand a little bit of Portuguese, right? You're not fun. I expect you to enjoy my jokes. Yes. And the exclusion criteria are shown here. I think you can read this better than myself. Okay? My Portuguese is so limited. But basically, if they have osteomyelitis, cellulitis, gangrene, and they have immunosuppression, they were excluded from the study. If they have renal problems, they were excluded from the study. And if the diabetes is not well controlled, we excluded them from the study. So basically, those are the criteria. And the study was approved as a protocol by several organizations. And here is the device we're using for this study. This device is different from the device that we used at the University of Kansas Medical Center. At the University of Kansas Medical Center, we used a device that has just a single diode, 830 nanometers, 1 wavelength. This device has multiple wavelengths. It has 32 diodes. My laser pointer is not working very well. I think the battery is dead. If we have another laser pointer, it would be helpful. But it has 32 infrared diodes and 4 visible red diodes. The total power output is 500 milliwatts. It's continuous wave, and our treatment, again, was like the same as Kansas, 3 joules per square centimeter, 2 times a week. Okay? And this shows the layout of the diodes. These are the 4 red diodes, 1, 2, 3, 4, 5 milliwatts each, 20 milliwatts of the red diodes. The 32 infrared diodes is what produces most of the power. So you can see here we have 500 milliwatts being produced by 36 diodes. 4 of those diodes are red, and those 4 only produce 20 milliwatts. So 480 milliwatts of the power output of this device is coming from the infrared radiation. This is very important to bear in mind because in order to have a control group and to have double-blinded study, we were not able to remove all the light. We had to produce 2 probes. 1 probe with 36 diodes producing light. 32 of those diodes are infrared, 480 milliwatts of power output. The remaining 4 are red, and they produce 20 milliwatts power output. Total is 500 milliwatts. That is the real probe. The fake probe, the second probe for control study, has the same setup, but all the infrared was completely knocked out. So they don't produce any infrared in the control probe. And all of these red were eliminated except one that produced red light. So when you look at them, they look the same. Red light comes out of this, red light comes out of this. You don't tell the difference between the two probes. So probe 1 and probe 2 for this experiment. Probe 1, or one of the probes was the control probe with only 5 milliwatts of red light. And the experimental probe has 500 milliwatts of infrared and red light. Is that clear to everybody? Okay. So that's what we use in this study. And you can see that just clean the ulcer, you dress the ulcer in the normal way. And all we did was just add the light treatment. As you can see in this example, in fact, I have a video. And after the treatment, the ulcer is again put together. You know, you put a Band-Aid and you put ACE wrap, and you wrap the ulcer up. We used a software produced by NIH called ImageJ to measure the size of the ulcers for accuracy. When you do this, you get computer reproduction out of which you can calculate the size of the ulcer. You can actually calculate the size of granulation and all sorts of calculations that you derive from that. This just shows you how the treatment is done. You'll see now that here we have, we're applying the light treatment. You turn the machine on and you have light applied to the area. You can see that this device produces light all around the periphery, but not so widespread. If you have any question as we go along, by the way, please feel free to stop me and ask a question. I think I should have said that from the beginning, but you can stop and ask questions. Okay? To save time, I will move forward. So larger ulcers we treated sequentially, one area at a time, another area until the entire size of the ulcer was completely covered with treatment. And you can see from this result, our very first patient, just like at the University of Kansas, the study we did over there, the first patient responded so quickly. In 2 weeks, the ulcer was completely healed. This ulcer healed just in 2 weeks. 4 treatments. And one of the things that Deborah observed in doing this study, again, here's our second ulcer. This one went over 12 weeks, but healed fully. Sorry, didn't heal fully, but went over 12 weeks. It was initial response, very quick response initially, and then it just flattened out. This patient was treated with probe number 1. The previous patient, the first patient, was treated with probe number 2. You have to pay attention to the probes now. So you can tell after a while that there seems to be a trend here. Here is the patient treated with probe number 2. Also healed fully in 2 weeks, complete repair of the ulcer. Also in 2 weeks. Patient number 4 has so many ulcers, about 3 or 4 ulcers on this one patient. Ulcer number 1 was treated with probe number 1. There was not a good response initially, but after about 8 weeks, it started to show some response. But still didn't heal fully. Probe number 2 was used for ulcer number 2 in the same patient, and that patient healed fully. There was a very big drop initially. It stayed a little bit stabilized and then healed fully by 12 weeks. With probe number 2, the same patient. We think that this patient, by the way, this patient number 4, this ulcer treated with probe number 1, maybe didn't really respond to treatment with probe number 1, as you can see initially, but the same patient was being treated with probe number 2 for other ulcers. So it appears that there was a carryover effect of treating some of the other ulcers on this patient, so that this wound, which was being treated with probe number 1, eventually healed fully. I'm sorry. And of course, this ulcer number 2 healed fully. Ulcer number 3 in the same patient, treated with probe number 2. I'm so sorry. I'm trying to use the laser pointer here, but you know, I'm going to take a few seconds. I have another laser pointer to use instead of this. Okay, this is better. So you can see that this same patient, number 4, the third ulcer also healed fully. These are fairly large ulcers, by the way. If you look at the size, 26.3 square centimeter, that's a large ulcer. So it took quite a while before that healed fully. And here's a very large one, 75.4 square centimeter, treated with probe number 2. Very quick, big response initially. Ulcer size decreased to about 30%, stabilized, and then healed fully. This is the type of trend that she's seen in all the patients. When you start to treat them initially, they respond very quickly, and then it plateaus over a while, and then starts responding again. One of the things that she observed just casually from doing this work is that those patients that are going to respond, in fact, all of them did respond, those patients being treated with probe number 2, as opposed to probe number 1, which we have now found out, probe number 1 is the control probe number 2 is the real probe. Those treated with probe number 2, within 1 week, will report to her that the pain is less. And we weren't interested in pain. We weren't actually measuring pain, but they voluntarily reported to her that they feel less pain. And in fact, that was how she began to suspect that probe number 2 might be the real treatment, because it reduced the pain in addition to healing the ulcer. And patient number 5, again probe number 2, healed fully in 6 weeks. Patient number 6 treated with probe number 1, no response. In fact, patient was taken away from the study because there was no response. And patient number 7 healed fully in 7 weeks. And number 8 treated with probe number 1 responded ever so slowly and gradually, not quite very good complete healing over there. Another ulcer in the same patient, number 8, responded initially well but stayed stable, didn't quite heal fully, even though we used probe number 2 in this same. But ulcer number 3 in the same subject healed fully in 7 weeks. Okay? Ulcer number 4, probe number 2, also healed fully in this patient. Now, you can begin to see a trend that those treated with probe number 2 are usually healed completely. Those treated with probe number 1 either didn't heal at all, or they responded and healed a little bit, but not completely, not as well, result not as good as we got with probe number 2. Therefore, we thought with this preliminary data, we now have more data actually. We have studies almost over. It should be all done in the next 3 months. But you can see from this initial data that 660 nanometer light and 880 combined with 880 nanometer light, the red light combined with infrared light, seems to promote healing of diabetic ulcers that fail to respond to other forms of treatment. I have to emphasize this. These are patients that were not responding to other types of treatment. These are not just your everyday diabetic ulcer patients. They have to be in the clinic for visited the clinic for at least 1 month without any positive result, no response. Then we recruit them and put them in the study. And then they respond with this treatment. So we are now doing further studies with a larger sample size to determine this. In 2005, people got excited with this result, and then they began to apply this treatment to patients with leprosy or with Hansen's disease. And you can see that they're beginning to get some, these are, again, Marco is involved in this, and Deborah, of course, is involved. This is one of the master's level students, Kelly. She's actually the one that did most of the work. And Professor Norma Foss, who is the head of dermatology over there, is also helping with this study. This is going on now. They're still looking at some patients with Hansen's disease. As you know, this is a neuropathic ulcer, and hopefully we'll find a way to heal these ulcers as well. Okay, so these are just some of the things going on. Now, the question is this: how does light heal these tissues? What is going on that just applying certain wavelengths of light result in healing of ulcers, in particular ulcers that do not respond to any other form of treatment? It turns out that we have now, over the years, begun to uncover the mechanisms involved. We still have some ways to go, but we have done quite a bit. So basically, I will use the scheme here to illustrate what happens with these ulcers. Basically, when the light is applied to the tissue, we're actually putting photons into the tissue. And photons are little packets of light energy. Okay? And the light energy, we now know, is absorbed in the mitochondria of the cell. In fact, it isn't just the mitochondria, it is the inner membrane of the mitochondria. And it isn't just the inner membrane of the mitochondria. It is that within the inner membrane of the mitochondria, there are certain chromophores, certain chemicals that absorb the light. And those include the cytochromes, the porphyrins, the flavins, the NADH, nicotinamide adenine dinucleotide, hydrolyzed form of it. All of them absorb the light energy. And that energy from the photon is then used by the mitochondria, which transforms this energy into the form of energy that the cell can use. So the mitochondria transforms the energy into ATP. We know this very well. In fact, those of you here in the Physics Institute can explain this even to others, because you do photodynamic therapy, don't you? And you do photodynamic therapy, and then you inject tumors with photosensitizing agent. The tumor absorbs the photosensitive agent, and then you apply your light. The light is absorbed by this tumor because it has this photosensitive agent in it. And when the light is absorbed by the tumor produces singlet oxygen, right? Produces free radicals, hydrogen peroxide and other singlet oxygen species. And then the tumor self-destroys itself. So you know that this process actually happens because you use it in photodynamic therapy. But it turns out that in the treatment of ulcers and wounds, that what happens is that the cells at these sites absorb the light, and the energy is used to produce ATP, which is then used to power all the needed metabolic processes, such as DNA synthesis, synthesis of RNA, protein synthesis, collagen synthesis, enzyme synthesis, cell proliferation, and whatever is needed by the cell. I have to sound a note of caution here, because a lot of people think that the cell will immediately begin to engage in all of these activities. This is not correct. The cell will only engage in the processes that are needed by the cell at that particular time. As a matter of fact, the cell may not even react to the light. A friend of mine at the University of California, San Diego, his name is Bob Navio, who is a molecular biochemist in the medical school there, has actually taken mitochondria from patients with diabetes. Harvested cells, extracted the mitochondria, and taken mitochondria harvested from cells of normal individuals, and then took these 2 sets of mitochondria to a laboratory in New Mexico in the United States, and then they irradiated with 830 nanometer light, infrared light, about 3 joules, 1 joule per square centimeter, just to see how these mitochondria will respond. And the mitochondria harvested from the patients with diabetes produce a lot of ATP in response to light, to the infrared treatment. But the mitochondria from the normal subjects almost didn't react at all. Almost no response. Very little amount of ATP was produced by them. So it appears that the response of the cell depends on the redox state of the cell, depends on the state of the cell. If the cell recognizes that there is a need for something to be synthesized, the cell will convert the light energy to ATP form of energy and use it to power the needed metabolic process. The cell will not just engage in any activity. Otherwise, it will be behaving like a cancer cell, which just does anything and everything at any time. Okay? So the cell will only engage in the needed processes. And that needed process might even be tissue repair or pain, result in tissue repair or pain control. We believe that this is the mechanism by which this is brought about, so that you could actually see, for example, in these videos that I will share with you. These are videos from the laboratory of Buehler, who is at Northwestern University. And Buehler does not study light therapy. It's not really interested in light therapy. Doesn't even know that people use phototherapy for tissue repair or pain control. Buehler is interested in looking at consciousness. He's interested in finding out the seat of consciousness. If you ask most people, where is consciousness? Most people will tell you that consciousness is in the brain. If the brain dies, then the person is no longer conscious. But Buehler does not believe in this. Buehler thinks that consciousness should reside at every level of the organism, in every cell. If consciousness is in the brain, how about the lower organisms that do not have a brain? How about bacteria? How about even viruses? Bacteria seems to know what it is doing. So if it knows what it is doing, somehow it has some level of consciousness. Maybe not as high as animals that have brains. So he's interested in this, and the way he tries to study this is he grows 3T3 fibroblasts in a tissue, in a cell culture, in a petri dish, and the cell is sitting there, and he comes and he starts flashing his infrared 830 nanometer light. Infrared, 830 nanometers, and starts flashing it in the petri dish, just like that. And he wants to see if the cell has consciousness, the cell will respond somehow. Okay? And watch how this cell responds to light. The light is being flashed right there, and the cell is moving. This is time-lapse photography, by the way. And the cell reaches out to the light. Okay, so you can see, and there are several videos here. I may have to skip some of them. Here's a situation where there are two pulsating light sources. Light is flashing here, another one is flashing here. Both are infrared. And here is the cell. Now you have a better view of the cell. And the light is being pulsated here. Will this cell respond to one source of light or both sources of light? Cell migrates to the closest source of light, continues its motion, and then reaches out to the second source of light, indicating to us that these cells do respond to light. And then many more, here the cell is migrating in this direction. You can see the arrow. And the two identical sources of light are placed behind the cell in the opposite direction to the motion of the cell. Will the cell continue its motion, or will it go back? And watch what happens. This cell reverses course, migrates backward, and goes back to the closest source of light and on to the next, second source of light, and reaches out to it, as you can see. Here they put an obstacle between the light and the cell. The cell is moving in this direction. There's an obstacle here. The light is pulsating on the other side of the obstacle. Will the cell know that there's light on the other side of the obstacle? Of course the cell does. And it finds a way to bypass the obstacle and goes to the light, as you can see. It's going to go around and eventually reach the light. And now you have a situation where the nucleus has been removed, and only the cytoplasm is there. Do you think this cell is going to respond? It should, because remember that the chemical that absorbs the light is in the cytoplasm. It's not in the nucleus. Therefore, if you remove the nucleus, the cell will still, those chemicals are still in the cytoplasm, and the cell will respond. And of course the cell responded, as you can see here. Here you have the cell moving very quickly and gets there to the source of light. This is even more dramatic. Here we have two cells, cell number 1 and cell number 2 over there, and the light is over here, very close to cell number 1. Now you think that cell number 1 will respond to this light very quickly before cell number 2, but that's not the case. If you look at this video, you find that the cell number 2 dashes across cell number 1 to get to the light. And cell number 1 doesn't even seem to respond to it. So again, this emphasizes the fact that the response of the cells or of the tissue as a whole depends on the redox state of the cell. It depends on the state of the cell. If the cell recognizes the need to establish homeostasis, normalcy, the cell will respond and do what the cell is supposed to do. So basically, these are some of the mechanisms. And in fact, I hope you are convinced by this video showing that cells respond to light very much the same way that plants respond to light. I hope you are convinced by the video that indeed these cells do respond to light. They are attracted to light, and they use the energy from the light to synthesize ATP, which is then used to support all the needed metabolic processes in the tissue. Yes, please. It's like type of phototropism, but we use the term phototropism for plants, but this is like photo attraction to the cells, yes. Let me ask you, how do you feel? Oh, in fact, this is a holiday weekend. Some people are not here because they've gone on holiday, right? Where have they gone to? I have two friends in São Paulo. Both of them told me they were going to Rio. They've all gone to Rio or Búzios, right? Yeah, and all these other wonderful places, right? Salvador Bahia and all the Recife, Fortaleza, right? Natal, right? They've gone to stay on the beach. Why have they gone there? Beautiful girls. Not really. Actually, I can tell you, I have a picture that I don't have in my slides today, but I show it in the United States. I took it on the beach at Copacabana Beach. It shows a very beautiful lady with her boyfriend, and they were holding their hands together walking along the beach. But this lady had very little around her. She was completely open and only very little G-string, or whatever they call it. Now, why do you think she was wearing the G-string? She was with her, she wasn't going to attract other men, right? Am I correct? Maybe. He said maybe. But I think she removed all her clothes because she wants to absorb more light. I think the women will agree with me, right? What did the ladies say? Is that correct? Yes. It wasn't because she was trying to flirt with other men, right? No. Yeah. The women agree, but the men don't agree. But anyway, basically, when you leave this room now, if you were to leave this room, there's no window here. If you were to leave this room and go outside, it's very sunny and bright outside. How would you feel? Would you feel anything different if you got outside? Would you? I need your response. You feel a difference, yes. And why do you think you will feel a difference? How long does it take for you to begin to see something different? To feel different? Right away, right? It doesn't take long once you get outside to begin to feel excited and happy and better. People that live very close to the poles, especially the North Pole, there are certain times of the year that they don't have enough light. And they have what is known as seasonal affective disorder. During this period, people are so depressed. They're down, they're not excited, they're grouchy. But then, when the sun comes out and everybody goes out, they are very excited, they're animated, they want to do something, they feel energized, right? Yeah. That's because of the mechanism that I just shared with you. Your cells are responding to the light. So your whole being is responding to the light, just like those cells responded to light. So because of this, I have created a model that summarizes the literature, a model in which look at injury that is induced. For example, when there is an injury, a hematoma is formed, and this is blood clot. And following the formation of blood clot, we have a cascade of activities involving the white blood cells. These white blood cells, such as mast cells, platelets, monocytes, macrophages, lymphocytes, they all come to the site of injury, all in an attempt to clean the wound and clean the damage. And once that is done, they release factors, several growth factors, fibroblast growth factors, and other growth factors. And at the same time, once the wound is clean, new blood vessels are formed at the site of injury. And following the formation of new blood vessels, then the fibroblasts will arrive at the site of injury. And the fibroblasts arrive, and then the fibroblasts proliferate, increase in size and number. And following that, they synthesize collagen, and the collagen remodels. This is how most wounds repair themselves, particularly skin wound. But it turns out that if you have cartilage and bone, you need bone to produce new bone. You need cartilage to synthesize new cartilage, in addition to this model. What the literature indicates to us is that all these cells respond to light. We have a lot of data now in the literature showing that mast cells are caused to release their granules of heparin and histamine to promote the process of inflammation. And the macrophages, upon absorbing light energy, their activities are enhanced to become more phagocytic as they promote inflammation. Therefore, inflammation is resolved faster. Faster resolution of inflammation then results in quicker formation of new blood vessels and quicker arrival of the fibroblasts to begin to proliferate and to begin to synthesize collagen. And in fact, the entire process is accelerated as a result. Light also enhances the action of fibroblasts, causes them to proliferate and to synthesize collagen. This is abundant in the literature. Similarly, we have data in the literature showing that even the formation of new blood vessels is facilitated by light. And the chondrocytes and osteoblasts also produce collagen and bone, respectively, respond to light. I have put an overlay here, and keratinocytes also respond, producing new skin. Odontoblasts similarly will produce dentin. Dentists here already know about this. And neurons, nerve tissues, also respond similarly. So you can see that all these cells respond to light. But how is it that they all respond to light? It goes back to the fundamental basis. They have mitochondria. They even have cell membranes within which we have chemicals such as cytochromes, porphyrins, and other light-absorbing chromophores that absorb the light. And then the cells then uses the light to produce ATP, and the ATP is then used to power needed metabolic processes. So, in summary, the mechanisms involved is that light energy is absorbed by chromophores within the ATP, within the mitochondria, inner membrane of the mitochondria, and also within cell membranes. And the light energy is transformed to ATP. This additional ATP, which is the form of energy that cells can use, is then used to power needed metabolic processes. The benefits of light therapy is to promote homeostasis. And I cannot emphasize this enough. It's to promote normal situation, normalcy, so that the cell responds to normal. If there is pain, the pain goes away. If the tissue is damaged, the tissue heals itself. Whatever it is that is needed is what the cell will do. Okay? Cells respond to light in the same way that plants do, as you can see from the video that I shared with you. When I lived in Kansas, we used to have a house that in one part of the house we put plants there. And the plants, there's just windows only on one side of this room. No windows on the other three sides of the room, but just one side. And what happens is that every day I would return from work, and the plants are tilted toward the window. So you can see that lights do this. It's called phototropism, as he said. The lights respond, the plants respond to light, they tilt toward the light. And then you turn the pot so that, I will turn it so that the plants, I want them to grow straight. I don't want them to grow like this. So you turn the pot so that now the plants are leaning this way. And the next day you come back from work, they've actually turned again to the light. All over again. It was a battle that I couldn't win. The plants always, eventually I left them to grow like that. So the plants grew like this toward the window. But you can see that cells tend to respond like that. And in fact, whole organisms tend to respond like that. This shouldn't come to us as a surprise because you should know from those people who study developmental biology and people who are familiar with cell biology know very well that there are certain bacteria that just survive only on light. Light is all they live on. I mean, the purple bacteria is a very good example. The purple bacteria is found in marshland and in some of the most abstemious conditions. And they live below the surface of the soil. And this purple bacteria absorbs light in the green color range of the wavelength. And that's all it uses, nothing else, to power all its metabolic processes. So the idea that cells can absorb light is not totally new, particularly if you come to realize that most biologists believe that the mitochondrion is nothing but a vestige of bacteria, right? You can see how this can be so true. I will try now to begin to bring this to a close so that there will be time for questions and answers and discussion. We, in 2004, published 2 meta-analyses. A meta-analysis is a statistical approach whereby you take all the published work in the literature and subject them to some statistical analysis, independent of the statistics that was done by the authors, and independent of the result obtained by the authors. And we did this meta-analysis at 2 different locations. And we found from this meta-analysis that there is sufficient evidence, in fact, significant evidence, for the use of light therapy for tissue repair and for pain control. That paper was those 2 papers were published in 2004 in the June and the August issue of Photomedicine and Laser Surgery. Okay? In conclusion, the light is now being used in other fields. In the United States, people are using light, red light, to grow plants indoors. Plants that wouldn't normally grow properly, and you can enhance their growth with red light. And now we have light also being used to grow different types of cells in culture. And these are cells that wouldn't normally respond, wouldn't grow very well under normal conditions. You can enhance their growth with different wavelengths of light. And so I'm going to stop here and thank you so much for your time. And hopefully we'll have some time for questions and discussion. Thank you. Thank you very much.
Questions? People are very timid. They will.
Yes. Don't be shy. If you can't ask the question in English, you can ask in Portuguese. Maybe I will understand the Portuguese. Just a little bit. I understand very little, but if I don't understand it, he will interpret it for me.
I'll try to help. One question.
Believe that potency of the LED that have height?
That the potency of the light has
You want to know if the level of power when you use LEDs or laser,
yes.
if
What's
you
the
have to use
maximum level
more LED power to get similar result with laser, or they are both similar?
This is a very complicated question that you ask, and I will try to address it in as simple a way as I can. If you have, basically, it boils down to the irradiance, the power density. If you have the same power density with a laser as you have with LED, you should have the same results. So whether it is a laser or not a laser is not the issue. The real issue is that you have equal power density. In other words, the power should be distributed over the same area equally in both cases. The power per square centimeter is the same, you should have the same result. But you do need to know that with the laser, the output is so narrow and so defined. So if you want to have the same distribution in space, you may have to use the lens to disperse the beam from the laser to get the same thing you get from the LED. Yeah. Put it closer to your mouth. Yeah.
Is there any after effects of the light therapy?
Yes.
Short time or longer time?
Is there any after effect of light therapy? So far, we haven't seen any deleterious effect or adverse reaction to light, except the following, that there are some people that are highly photosensitive. Their skins are very sensitive to light. And with these people, we're beginning to see some problems. In addition, we also have patients who are on certain medications, some medicines that they're taking, and they're reacting to light negatively. Not negatively because it doesn't heal, but negatively because the skin is being discolored in these people. For example, if a patient is on quinine type of medicine, like anti-malaria type of medication, you have to be very careful with them. Yes. And also if they are on some antibiotics, such as tetracycline, we have also heard some cases of patients responding to that. There are patients who are taking multiple medications, different types of drugs, maybe 4 or 5 combined. And we have cases in the United States where the patients have actually had reaction, skin reaction to this type of treatment. So those are the only ones that we are aware of. We do not know of any other contradicting effect. These effects, as you can see, they seem to be related to other factors, not the light itself. The power output is so low, and the amount of power density and energy density required to achieve these results, positive results, are so low. So therefore, consequently, there isn't any such adverse effect, except one has to watch out that the patient is not on some medication that will enhance sensitivity to light.
The big problem when you talking about the diabetic ulcer, mainly, is the infection. Okay.
Yes.
Right. So when you find it, the infection and the ulcer, diabetic ulcer, what do? You use antibiotic talk. You use antibiotic system. You like to, for example, I don't know, mechanical clinic.
Yes.
What do you do in this case?
Yes. In the study that is going on now, she's using sulfadiazine. They clean the wounds and they put sulfadiazine, which helps to eliminate some of the infection. And then the light therapy is added to it. And she's comparing patients treated with this sulfadiazine and dressing without and with the control light versus patients treated with sulfadiazine, the dressing, with the real phototherapy. So that's what we're doing. So you can use that to do that. But having said that, we have seen there have been some publications in the literature showing patients that have been showing cases of bacteria that have been destroyed with light very close to ultraviolet radiation. Not UV, but very close in wavelength. So 470 nanometer light, 405 nanometer light. These have been reported in the literature that you can kill Staphylococcus with this type of light, and also with and Pseudomonas, also with this type of light. So, so basically, there are studies going on now in our center in the United States. We're looking at blue light as a way to eradicate bacteria. Yeah.
Very good idea.
Thank you. Yeah.
I love that movies. Do you think that the cells could react as the same way if you use the red light as you use infrared.
If you use the red light?
Yes.
That's a very good question.
Or you believe that red light could change other things?
I think the red light will cause the cells to react in the same way. However, the reason that Buehler used infrared is very simple. If you use red light, it could be argued that it was the color that attracted the cells. He used infrared, which is invisible, because he wanted to demonstrate that these cells have the consciousness to recognize that there's an energy somewhere nearby, and then they rush to the energy. So that's why he used that. I think you'll get the same result with red light. It would be nice to see somebody do this type of study. Yeah.
How is the explanation about the video with two cells, and one not respond, and another one as distance is much more,
yes,
and respond?
Yes. I didn't show you all the video. There's some video we have of cells that are undergoing mitosis, and the response is different. In fact, when the cells are undergoing mitosis, they hardly respond. But to answer your question more directly, I think what happened here is that you have two cells. One cell has perhaps enough energy for what it is doing and doesn't need any additional energy to enable it to do what it needs to do. But then you have a cell far away that recognizes that there's a source of energy that could help it to accomplish whatever it is trying to accomplish. It rushes to the energy and gets there and tries to absorb the energy. So you have two cells that are at two different states. The cell that responded, cell number 2, was in such a state that it really needed the energy more than the cell number 1 that was in a completely different state. I think that's the case.
Last Saturday, we talking about the bacteriostatic form in
Yes.
treatment disease. Did you remember?
Yes.
Okay. When you're talking about in medicine, in bacterial disease treatment, you have basically two forms of treatment. All right. Bactericidal treatment form or bacteriostatic form.
Yes.
Okay. So, did you make some report or some research in bactericid form treatment disease? Or did you read? I don't know.
Well, the papers published indicate bactericidal effect.
Bacteriostatic form,
Yes.
not
Is-
bactericid. That's my question. different.
Bactericidal or bacteriostatic?
Yeah, bactericid treatment, no bacteriostatic form.
It is bactericidal,
Yeah.
destruction of bacteria,
Yeah.
not bacteriostatic effect.
Oh, great. Thanks a
Destruction
lot.
of bacteria. If you count the colonies after you have done the treatment, there are less bacteria. In fact, in some cases,
It's similar to chemotherapy, for example. Similar of chemotherapy, for
chemotherapy,
example.
yes, very quite similar. Yes.
Thanks a lot.
Yeah.
Do you use LED in bone regeneration?
No, I don't do bone regeneration studies. But people are doing LED studies with bone regeneration here in Brazil. You have Professor Pinheiro up north in Bahia doing studies on this. And he has been doing this for years. And there are other people here, too, that are working in this area. But I don't do bone studies, bone regeneration studies.
First is, you know that tissue engineering, which means grow the tissue before implanting, is a new field that's going on.
Yes.
Do you know any paper that people use laser to enhance the growth of cell in tissue engineering?
Yes, there are papers. There are two areas that people are doing this. I'm sure you'll be very interested in knowing this. Nerve tissue regeneration, particularly in the spinal cord, where we have Shimon Rockin at Saraski Medical Center in Tel Aviv, doing work in this area. And then we have a group from Italy Gardarella is the name of the lead person there. And I'm trying to remember the name of the university. I confused the two universities. I suspect, I want to say University of Torino, but I'm not so sure that that's correct. But his last name is Gardarella. He's the lead author there. They're using light to stimulate cartilage cells, chondrocytes, to produce cartilage. They're
That's
from the
extra
department,
body.
yes, in culture. They will stimulate the cells and then they inject into defects. There's another group at Nihon University in Tokyo, Japan, also a department of orthopedics. They're also doing work in this area and also looking at how to make cartilage cells repair cartilage better and produce hyaline cartilage, which is a very big challenge today. It isn't possible to, it is very difficult for cartilage to repair itself and produce hyaline cartilage. You do get cartilage, but it is scar tissue type of cartilage. Hyaline cartilage is a smooth cartilage that you have on the surfaces of joints, and it permits the smooth motion of joints. And that's what is missing, that after injury to cartilage, producing that hyaline cartilage is a very big challenge and difficult thing to do. So that's why most people that have cartilage damage hardly return to high-level athletic performance. Yeah. But those are the groups that I know who are doing this. Yeah.
Okay, we have a question of the lady here.
Yes.
Eu gostaria de saber que
Yes,
em casos de úlcera de pressão, se usa só o laser ou se pode usar outros medicamentos.
Please help.
She wants to know that in case of ulcers of pressure,
Source, yes.
yes, if we use the laser only, or if you recommend the laser only, or if you associate with some other kind of medication
Yes.
or whatever.
In all of these cases, it isn't advisable to use the light or the laser only. It is not advisable to do that. You have to combine it with other existing forms of therapy, especially with pressure ulcer. Because if the pressure is there all the time, if you treat with light, and the pressure is there all the time, you will still have very poor result. But if you help the patient by relieving the pressure from the ulcer and then treat with light, then you're likely going to get a better result than just relieving the pressure and dressing the ulcers. If you relieve the pressure, dress the ulcers, and apply light, you get a better result than just relieve the pressure and treat the ulcer. So in all these cases, you have to add light as an additional form of treatment. Second question now.
My second question is, how cells identify light? If the light is far away and no light beam is getting to the cell in your video.
How does the cell know that there's light there? And
Yes.
the cell is not, yeah, that's a very good question. I'm not so sure that I have an answer for you. I can't explain how the cells.
Well, maybe some scatter light, because light is scattering the medium
Yes,
and the cell. So,
it is possible, yeah.
yeah, but could also be, you think, that the light is establishing a kind of gradient,
Yes,
of thermal gradient.
yes.
And then this is what is triggering the
It may not be thermal gradient. It might just
intensity
be
gradient.
Yes, it may just be intensity gradient. For example, how does a plant inside the house that you plant in the house know that the window is here, and that's where the light is coming from? I'm sure there's photons being scattered, and there's a gradient of light intensity between the window through which the light comes in and the far wall where there is no window, right? And so the plant is able to identify that, well, there's light in this direction, but it seems to be more in this direction and turns toward that light. Perhaps the same thing is going on here. Yeah.
Okay, well,
If there are no more questions, let me thank you so much for your time, and I appreciate you taking your time from a holiday. I'm told today is a holiday here in the university, and I appreciate you taking the time from your holiday to be here. Thank you.
Well, we would like to thank Dr. Chuckuka for coming. It's a long trip, you know, from New York. And mostly important, he left behind a lot of work. He's one of the chiefs of the university that he's engaged, and he left everything behind. So we would like to show our appreciation that you left all the things out and came, and we hope that this is the seed of important collaboration, that in the future we also can give some of your time for your research and everything. So thank you very much for coming.
Thank you.